Well, it's my pleasure to introduce our speaker this morning, Dr. J. Brian Kim. As you all know, Dr. Kim is an assistant professor of cardiovascular medicine and a practicing interventional cardiologist. What I did not know about him was that he split his time growing up between the UK and Korea. He then studied chemical engineering and biology at MIT, followed by medical school at NYU. And then he came out to the West Coast and did his internal medicine training at UCLA and was mentored in genomics in the lab of Dr. Aldons Lucis. We were lucky to recruit him to Stanford for his cardiology and interventional cardiology training. And as a fellow, he studied regulation of smooth muscle cells and atherosclerosis under Dr. Quatermass. His research now spans from macro to nanoscale, focusing on gene-environmental interactions in risk for cardiovascular disease. Dr. Kim, thank you so much. We're excited for your talk.
Thanks, Yannick. Thanks for having me. Yeah, I think so. Yes. So thanks, Yasna and Yannick, for inviting me to Grand Rounds. It's been a few years, but I'm really excited to be back, and also good to see everyone in person. So thank you for being here. So today I want to talk about particulate matter air pollution and cardiovascular health. And it's a topic that we don't talk about here too much because our air is very clean, but I think it's a growing issue, and it's a timely issue as well. So today, I want to talk about what particulate matter is, and just provide a brief history of air pollution and its impact on health. And then I want that to sort of provide some context to where we are right now in terms of our regulations for air pollution regulation. And then go over some epidemiology about the effect of air pollution on particulate matter pollution on cardiovascular health. And then we'll briefly talk about some of the mechanism and how particulate matter affects cardiovascular risk factors. And we'll sort of flip to kind of a more clinician mindset to think about some susceptible and vulnerable populations, what the clinical implications might be and what we can do to mitigate. And if we have time, we'll go over some novel sources of particulate matter air pollution like wildfire and vaping. This is our CME objective. So air pollution really has evolved, I think, over the last 100 years. Basically, things have progressed. I think these are the common components of air pollution. So particulate matter, gas like ozone, nitric oxide, carbon monoxide, and black carbon, normally called soot, toxic organic compounds like formaldehyde, acrolein, benzene, hydrocarbons, and metals like arsenic, lead, mercury. And in the old days, the Industrial Revolution around them, black carbon, sulfur dioxide was really the dominant form. Whereas at this time, nitrogen dioxide and particulate matter pollution really is kind of the dominant form due to basically changing regulations and changing form of energy source. So we're going to focus on particulate matter today, which has the most robust and amount of data behind it. And particulate matter really is a mixture of a ton of things. It's a mixture of particles, including metals, organic compounds, and black carbons, as well as nitrates and sulfates. And because of their really heterogeneous type, they're classified by size, not by their content. And we typically refer to them as PM10, which is less than 10 microns, PM2.5, less than 2.5 microns, and then 0.1, which are sort of these ultra fine particles. And once you become sort of less than 2.5, there are these fine particles that can start to travel down your alveoli and they start to enter your circulation via your capillaries as well. And when we think about the sources of these particulate matter emissions, in the US, most commonly is the fossil fuel combustion. So from vehicle use and basically diesel exhaust, and these coal power plants are still a large source of ultrafine particle and PM2.5 emission. House sources like indoor heating, cooking, and tobacco smoke, these are generally much higher source of emission in developing countries that can go up to sort of 30–40% in developing countries. And then the road dust, crustal materials are in that sort of higher range of particulate matters in size. And then the fastest growing source are perhaps a result of climate change with increasing wildfires around the world and dust storm. And then there's this concept of climate penalty where because of the climate change and induced temperature changes and weather changes, there's increase in ozone and PM 2.5 levels. So kind of this concept of air pollution causing health issue is not new. It's not sort of a 20th century issue, and really goes back. I think there was a person called John Evelyn back in 1661. He was ahead of his time for sure, but he wrote this report called Fomi Fugium, and it says the inconvenience of air and smoke in London dissipated. This is a report actually dedicated to King Charles II, who was the founder of the Royal Society. And I wish I had a British accent to read this, but I don't. So I'm just gonna read a little bit. But the issues belongs to the brewers, dyers, lime burners, and salt boilers. Whilst these are belching it forth their sooty jaws, City of London resembles the fact rather of Mount Etna, Stromboli, or the suburbs of hell. Wow. So there's no pictures in this book, but basically you could kind of imagine it. That hellish and dismal cloud of sea coal with its fulginous and filthy vapor corrupting the lungs. 1/2 of them who perish in this city die of physical or pulmonic distempers, that the inhabitants are never free of cough. And when they sort of look back at the estimated mortality around this time, it was basically 1 in 32 people died every year in London, compared to about 1 in 50 the rest of the country. So there was definitely higher mortality in London at the time. And he actually proposed these replacing sea coal with wood burning, removing polluting industries from the city, recommended banning cutting of large trees and planting flowers and vegetations, which especially with the very sweet smelling flowers. But it's really ahead of his time. But unfortunately, none of this was really accepted or they did anything about it for the next basically 2 or 3 centuries. And it got to a boiling point after the second industrial revolution that it resulted in these sort of massive catastrophic air pollution events that really sort of triggered the next phase of regulations or to kick in some regulations. So this is a brief video I'm just going to play about the
It started on the 5th of December. Fog laid a blanket over the London area. The fog and smoke mixed together in a dark, yellow, choking mass.
Smog has become one of the greatest mass murderers of modern times.
To see somebody fighting for air is a harrowing experience. Trying to get air into their lungs. And of course it was dirty air. You couldn't see your feet. And I remember on one particular occasion, I wanted to cross a very wide road. I shuffled across, and after about 10 minutes, I didn't know where I was, and finally I ended up on the same side of the road as I started.
As the 5 days passed, the emergency built up. Ice and frost joined in to make matters even worse.
It was extremely cold, and of course Londoners wanted to keep warm, and so they burnt coal on their open fires. The pollution didn't rise up, it tended to drift down and pervade the street and everything else.
Special filtering body masks are the latest weapons devised to combat smog.
Quite a number of people had bronchitis because of industrial pollution exposure and because they smoked. When they breathed polluted air, this became very hard for them.
Heaven help the doctor on a night like this. What can you do when the records and experience tell you that the city's death rate is about to jump?
As many as 100,000 people in London were made ill by the pollution at the time, particularly people with asthma, cardiovascular problems. There were estimates that there were 4,000 excess deaths, and there was a shortage of coffins because there were so many people who died. The government recognised we need to study this pollution, and that is why we set up an air pollution research unit in Bart's Hospital in central London. And I was found a member of that unit in 1955. There were 3 of us.
If the smoke appears to be darker than this point here, then an offence has been created.
In 1956, the government decided to pass something called the Clean Air Act to try and discourage and minimize the amount of smoky fuels being used. We still had smog, but as time went on, we had the availability of smokeless fuels like natural gas, like oil. Without that, we'd have been in a bad way.
It started on.
So that was a little depressing, but it only lasted 1 week in terms of the smog event itself. But the health effect actually lingered for several months. And during that 1 week period, about 4,000 people died, excess compared to the year prior. And then an additional 8,000 people died in the next 2-3 months. And bulk of that was due to pulmonary issues, bronchitis, influenza, TB. These patients with these comorbidities had about 10 times or 7 times higher mortality. But heart and circulatory system disorder was also reported to be 3 times higher during this time. And US was not immune to these type of air pollution events. And the most severe was in a town called Donora in Pennsylvania in 1948. And this is where American Steel was placed. The zinc factory was there as well. And then a sort of an inversion event occurred where it trapped air, and it had the population was about 14,000, about 6,000 people in that town had moderate to severe symptoms. And during a phase of 5 days, basically, about 40 people died during that time. And so that triggered President Truman at the time to sort of open this first air pollution convention or air quality convention in 1950 to start talking about potentially having some type of regulation. And then New York City had these smog events, 1953 and 1963, where basically several hundred people died at the time, between a window of 5 to 7 days when they had these extremely high serious smog events. And basically that triggered the legislators to really do something about it. There was a lot of consensus, and there was a bipartisan work, which is sort of hard to believe, but they basically passed this Clean Air Act in 1963 at the time. And then Lyndon, I think it was Lyndon Johnson. And basically at the time, with the first version of it, it was really about kind of more money for research, more money to do something. But the amendment in 1970, along with the establishment EPA in 1970, really started this regulation of air quality. And then they set up something called the National Ambient Air Quality Standard in 1970, where basically they set these criteria pollutants, which are pollutants that had some scientific evidence behind it. And at this point, there are 6 criteria, which is particulate matter, carbon monoxide, lead, ozone, and sulfuric oxide. And so they set it up so that there needs to be some adequate margin to protect the most susceptible groups, which are elderly, children, people with comorbidities. And then it had many amendments since then, including correction of lead, including acid rain, things like that. And then sort of what they proposed at the time, the early version is just looked at the basically total suspended particles. And then they had some annual level and 24-hour exposure level. And then in 1987, they sort of introduced their first PM10 concept into that. And so these were based on multiple time series and some longitudinal studies. And so there wasn't too much evidence based, but they did their best with whatever was available. And it wasn't really until 1990s that there was sort of these large prospective cohort studies started to come forward to help to understand this epidemiology a little better. And so this was the first real kind of landmark study on this. This is called the Harvard 6 Cities study. And basically it was a prospective cohort study of 8,000 adults followed for about 15 years. And they did a Cox proportional hazards regression just for individual risk factors. They recruited these cohort from 6 different cities in the US, and they had sort of different profiles of air pollution and particulate matter pollution. And you can see like when they sort of plotted the average total particle level that year versus the adjusted mortality ratio, there was sort of this trend And when they actually just looked at the fine particle concentration, there was a remarkable correlation between the fine particle concentration and the adjusted mortality rate. And you can see that also in this Kaplan-Meier curve, where Suberville, Ohio, basically there was a much increased mortality. And they estimated that when they compared the most versus the least polluted city, that the sort of the marginal risk conferred for every 10 microgram per cubic meter of air pollution, PM 2.5, was a 37% increase in cardiopulmonary death and 26% increase in all-cause mortality. And so this is met with a shock. And there was another study in 1995 that looked at basically, this is a prospective cohort of 500,000 patients from the cancer prevention study cohort, actually. And they studied these patients for 7 years. And basically, this is a subset of greater than 1 million patient cohort who actually had air pollution data and risk factor data. And they found something very similar, basically that there was a 30% increase in cardiopulmonary death, and all-cause mortality death was also increased in sort of this chronic exposure. And so based on that, the EPA had basically amended their air quality standard. And this is the first time they included the PM 2.5 to their standards and regulation. And they set that average limit at 15 microgram per meter cube. So since then, basically 25 years follows the 25-year big cohort studies. It also includes extended follow-up of these two initial cohorts. But what they found was that there was remarkable consistency in terms of the relative risk that they found. And it showed that the relative risk was consistently at around 1.1. So like about 5 to 10% increased hazard risk. Sorry, it's running on its own. And so, I think that provided a lot of data that also allowed us to sort of look at, how much is too much, in the sense that when we start to look at these, cohort data, we realize that the risk starts to increase even at very low levels of concentration. So this is the original study, and the fine particle concentration is at 10 microgram per meter cube, and there's the risk starts to increase there as well. And this is Arden Pope's paper in 2009, where they actually decided to plot, using the cancer prevention study, to plot the smoker data along with the sort of the secondhand smoker data, as well as the particulate pollution, the PM exposure patients data. And this is an important one, so I'm going to spend a little bit of time here. But one thing you'll notice is that all these circles here are the smoker data. And then along this axis here, the y-axis, you can see all these dots, which are the secondhand smoke and the particulate matter exposure data. So first thing you notice is that there's extremely, the active smoker exposure, the estimated daily dose of PM, is much, much higher than the particulate matter pollution or the secondhand smoke. However, when you start to sort of think about the data that we have, the marginal risk actually conferred by these very low exposures are much higher than what you would expect if you were to just sort of draw a linear line down from the smokers' data. And so there is basically a sort of much steeper exposure response relationship at the very low dose levels of exposure. And it also suggests that the marginal risk conferred by these very low dose is much higher than at increased levels of PM 2.5. And this is also sort of, you can see, even when you even look at the smoker data, bulk of the excess risk given by the smoking actually starts at very low levels of smoking as well. So even this is 20 cigarettes a day, this is less than 3 cigarettes a day. And even at less than 3, you're starting to see this 1.7 kind of relative risk. So that was, basically at the very low dose, there seems to be a very large marginal risk. that's occurring. And they try to basically bring in some other pollution or PM exposure cohort studies like the Harbor 6 cities, Women's Health Initiative studies, and that relationship persisted. So this is a kind of important point that I think that really made the regulators kind of think about the importance of regulating the low dose strongly. And in 2024, most recently, they actually lowered the PM2.5 average limit to 9 micrograms per meter cube. So with all this, the Clean Air Act really between 1970 and 2019 had a aggregate emissions of the common air pollutants dropped 77%. And then the particulate matter lead emissions actually fell by more than 80%. And the impact of this Clean Air Act is, if you just look at year 2020, the estimate is that it prevented 230,000 mortality. It also prevented 200,000 myocardial infarction. It prevented 17 million lost work days. And the aggregate just in the last 10 years is prevention of 2 million deaths and 1.8 million myocardial infarction. So it's really considered to be one of the most successful laws and legislation in the US with amazing cost benefit impact as well, with an estimated benefit of $2 trillion. So I think, we kind of know at this point what the good level of PM2.5 should be. We know that we want to be around that 10, less than 10. So let's sort of talk about where we actually are. And so Palo Alto, anybody take a guess on the average annual PM2.5 concentration in the last year? 6.5. So we're doing pretty good. So the average exposure in the US is about 9. So that's the sort of the annual exposure level. The WHO guideline is 10 or below is the recommendation. And then New York City is 12. Smoking 1 cigarette a day is equivalent to about 22. And then we start to go kind of more globally. Asia, across the whole Asia, the average is about 35. New Delhi is 225. And Oregon, during the wildfire season, was about 250 during the month of September. And then indoor burning of solid fuels, you're getting up to that 300 range. So let's talk about the burden, what this means. Like at this level of exposure, what does that mean in terms of global burden? And in the US, you can see this is sort of the distribution of air pollution, but if you look at the scale here, we're talking about 4 to 14. So US is doing pretty well. When you average this whole thing, it's about 9. You start to go globally, basically this is 10 right here. And so you're starting to see that about 90% of the population in the world is living above that WHO guideline of 10. And when you look at countries like China, India, Bangladesh, Pakistan, all these countries, 100% of their population is living above the WHO guideline. And so despite the low relative risk, I guess, of air pollution exposure, if you start to think about the number of people who are actually exposed to these level, we're talking about 7 billion people exposed to these hazardous level of air pollution. And so quickly it becomes the top 4 leading risk factor for global mortality. And when you think about how many people actually are attributed, the death is attributed to this, about the calculation is about 7 to 9 million premature deaths annually in 2019. And out of that, about 5 million are from cardiovascular disease. And this is sort of a New England Journal article from 2021 that showed that out of the 5 million, about half is about ischemic heart, other half is stroke and some hypertensive heart disease here. 60% of that is attributed to ambient air pollution, which is sort of from diesel exhaust and vehicular exhaust, and then about 40% from household pollution. The trend is that the household pollution is currently decreasing as developing countries are changing their energy source at house, but the ambient pollution continues to increase. And so when you think about mortality from 1990, there was a 50% increase in mortality from air pollution since 1990, but it's actually continuing to rise. and death is actually expected to double by 2050. All right, so that was kind of heavy. We're all going to die. But so I think we're just going to kind of switch gear a little bit, cool it down a little. So let's talk about the mechanism of PM 2.5 associated, the cardiovascular disease. And so, sorry. These studies are hard to do now, but people used to do these human controlled exposure studies. So they would sort of create these chamber and put people, get volunteers, they would pay them, they go in these, they put diesel exhaust into the room at about 300 micrograms per meter cube. And then basically they, sort of did lavage. They sometimes did bronch studies. And then they also did treadmill. But here, basically, they found that in the lungs, they found that there was increased percentage of activated neutrophils. They also found that there was change in the blood viscosity and the sort of TPA levels. And this New England Journal study in 2007 basically included 20 men with prior myocardial infarction. And then in two separate sessions, they put them into either filtered air or diesel exhaust, and then had them exercise for maybe about 30 minutes, 40 minutes, and then looked at their EKG to look at their ST segment depression and sort of the integral of the time and the ST segment depression to show that they had higher ischemic burden in patients who were exposed to diesel exhaust studies. And so some of the this is kind of a busy slide, but I think in general, there's a few categories of potential mechanisms. And one is sort of the lung inflammation and oxidative stress, increase in reactive oxygen species. And basically these inflammatory mediators and cytokines spill over into the circulation to cause a heightened inflammatory state, increase in oxidized phospholipids and oxidized lipoproteins. And then there's sort of the concept of direct transfer of these small fine particles into the circulation. So the alveoli reaching your distal organs and reaching the heart and the vasculature. And then, we actually ingest these as well. So they can change your gut microbiome and your metabolome. And then they get absorbed by your central nervous system as well, reaching sort of changing your adrenal hormones and autonomic balance. It can increase your sympathetic tone. Basically, all this leads to these issues, which is basically it can increase your blood pressure, it can increase dyslipidemia, it can also increase insulin resistance and obesity. And there's basically reports of all these if you search. And it can also increase change your vascular, sort of increase vascular dysfunction, endothelial dysfunction as well. So these well-known risk factors are also increasing in prevalence and as a result of air pollution. And there's also evidence that PM 2.5 directly increased atherosclerosis in animal models using rabbit and mice. And then in these prospective cohort trials, they found that there was increase in carotid IMT as well as CAC scores at low levels of exposure as well. So I think one thing I want to sort of just emphasize is the point that you don't choose where you were born or where you live. And so, when you're born or when you get conceived, you're already exposed to these levels of exposure. So there's sort of this concept of this cumulative exposure across the life course. I kind of took this from Josh a little bit when he talked about FH, basically sort of when you're born with FH, you're immediately exposed to higher levels of risk. And basically, with this high level exposure from very early in life, you start to increase the risk of basically developing these risk factors like hypertension and obesity, and also start to develop these plaque early. And basically, you sort of reach a point where these become unstable, or if you have acute sort of exposure to high inflammatory state or very high air pollution, they can rupture and lead to actual cardiovascular events. So this air pollution is really one of the social determinants of health. And we can think about that if you're exposed early, it puts you in this trajectory that's very, fast early in life. And then if you can intervene early enough, you can change that trajectory early. So again, sort of like similar to the FH kind of concept. You want to get statin early, you want to get intervene early. And then this is sort of just looking at the under 5-year-old population of the world. And you can see that much of the population that's under 5 are still living in areas with air pollution that are pretty serious. So let me just summarize that first part of the talk. So exposure to PM 2.5 pollution increased morbidity and mortality from cardiovascular disease even at very low doses. Chronic exposure to 10 microgram meter cube of PM 2.5 exposure marginally increased risk of CVD death by 6 to 10%. Increased formation of progression of atherosclerosis has been seen with PM 2.5 pollution, as well as increasing risk of risk factors for cardiovascular disease like hypertension, obesity, and diabetes. And then let's not forget the cumulative burden of disease from fetus to adulthood from PM 2.5. And then causes significant global burden of disease around the world, where 90% of the population live in an area with hazardous air pollution, and the burden continues to grow. So I think we're going to kind of switch a little bit to think about, okay, so what should we do about it? What do we know about sort of mitigation? And so does PM reduction result in improved health? It's not proven, but the New England Journal, there was a Arden Pope again, sort of looked at comparing sort of the 1980s data to the 2000 data, where we had some improvement in PM, and found that basically reduction in PM had a strong correlation with improved mortality. And they basically calculated that decrease about 10 in the concentration of fine particulate matter, estimated life expectancy increase of 0.61 years. And these are all kind of natural experiments in a way. And there was another natural experiment done during the Beijing Olympic. This is just a biomarker study, but basically they saw that Beijing improved their air quality by 30%, and that led to basically improving biomarkers of inflammation and all that. But at this point, basically, there's been scientific statements from AHA, expert position papers from ESC suggesting that there's overall evidence is consistent with a causal relationship between PM 2.5 exposure and cardiovascular morbidity and mortality. And PM 2.5 is deemed a modifiable factor that contributes to cardiovascular morbidity and mortality. And same thing in the ESC paper. It should be viewed as one of the several major modifiable risk factors in prevention and management of cardiovascular disease. And many more papers on from AHA, circulation, scientific statements, policy statements, New England Journal came out since then. And I think COVID kind of took away some of this sort of momentum. But I think one thing to remember is that long COVID is much worse when you have high air pollution. Oh, sorry, I don't know why it's jumping. Okay, and so I think we should, based on all this, we should start thinking about sort of, as physicians and clinicians, sort of identifying patients that are susceptible and vulnerable. And susceptible basically means that when exposed to the same dose, you're just at higher risk of developing, more health outcomes. And these are patients that are older, children. And children are also, they spend more time outdoors, they breathe faster. So their breathing rates are much faster, meaning they're actually, for their body size, they're taking in a lot more particulate matter. Pre-existing respiratory and cardiovascular disease, organ transplant recipients, obesity, diabetes. And this was evident in the data even from the great smog. The young children are very, they're higher risk there compared to the older, the sort of medium patient, as well as the older patient. The other concept is the vulnerable population, which is basically sort of air quality is often worse in locations where residents are socioeconomic disadvantage and are more likely to face higher levels or more toxic mixtures of pollutants. And low-income urban communities with poor built environments near major highways, near industrial regions, lack of access to clean energy sources can all sort of lead to being more vulnerable. And this is a study just looking at California, Northern California, and you can see sort of the San Joaquin Valley here, San Francisco here. And when they looked at sort of a cohort, this is a retrospective cohort study, they found something similar with all the other studies. The cardiovascular mortality was, here actually a little higher, 30% increase in this model. But I think one thing I just wanted to show, one of their figures kind of showed the impact, the interaction with socioeconomic status. And you can see that the low socioeconomic status, the fourth quartile, basically had the highest risk across all incident AMI, IH mortality, as cardiovascular mortality in this group. And there's some other literature on racial ethnic disparities of air pollution, and it's quite real. This is a study in Science Advances where they looked at the total exposure. This is the person of color, Black, Hispanic, Asian. The total exposure level is higher on average compared to white population. And then these are sort of all the different potential sources of PM emission. And basically, the red is sort of having a disparate exposure, meaning more exposure from these sources. And person of color, basically 78% of 78% of the sources were disparate, meaning that they were getting more exposure from 78% of these potential sources of exposure. And most often they included industrial, light duty gas vehicles. And this is another study in an environmental health perspective. They show that minority versus white, there was basically further increase in PM 2.5 exposure, especially in these regions, I guess, in the United States, California, and sort of the Rust Belt area. So I think these are things to keep in mind, but let's talk about some strategies for intervention and mitigation. And this is from a New England Journal article of 2021 from Sanjay Rajagopalan. And this has been reiterated in several different publications, but I think one thing to remember is that we have to sort of take two sort of different approaches when we talk about air pollution. One is kind of a patient-centered strategy, where we look at, kind of as a clinician, each patient on their own merit, and then look at the kind of the more societal and governmental strategies to try to do something about it. And if you look at sort of, we have to sort of educate about and communicate about the pollution risk, and then sort of figure out ways to kind of improve our monitoring at low cost. And then thinking about urban infrastructure, clean energy initiatives, emission trading, and shifting to renewable energy. And then sort of thinking about green space, where we live, urban redesign. And these are all things that I think advocacy matters, politicians, and we all have to work together. But let's focus on what we can do as clinicians here. I think, kind of having some kind of algorithm. I mean, if you think about sort of air pollution and PM 2.5 levels that's above 300 on a daily level, the recommendation would be to do something about it, regardless of whether you're susceptible or not. And that includes using N95 mask, staying indoors, using a HEPA filter, air filtration, avoiding these areas. And then some other strategies to think about if you have a susceptible patient, which include all these risk factors, high ASCVD risk, diabetes, CKD, patients with heart failure, COPD, asthma, elderly children. And if your exposure rate is fairly high at that time with a daily PM exposure greater than 35, you start to think about these interventions as well. And then if you have sort of this chronic exposure risk, I think the recommendation would be to continue to managing your risk with usual sort of these primary prevention, exercise, medications to reduce your LDL, and then trying to basically sort of stay in sort of areas with air conditioning as well as air filtration as well. And so it's important to sort of educate the public about what to do. Let's say if you have high high PM 2.5 concentration, but it's also important for them to know what the PM 2.5 concentration is. So there are these personal exposure monitoring ways. So there are apps in your phone looking at air now, air quality, and they can sort of tie to your Apple Watch these days to notify you if you have high air pollution. There's a device called Flow 2, which is from Plume Labs, and they can basically, it's a portable device that can give you a very detailed monitoring of your air pollution, air quality at the time. And with that, you can link that up with the air quality index and the EPA recommendations for that. and generally sort of AQI between 50 and 100. Unusually susceptible people start to pay some attention. When it starts to go above 100, I think that's when you have to sort of advise susceptible patients to try to really stay indoors, try to avoid any exertion outdoors. And then when it starts to go 150, I think that's when general public should be more concerned. You should sort of think about, taking steps to reduce exposure at the time. And so these are things that we can educate our patients and even physicians, because I'm not sure if, we can't really assume our clinicians really are aware of all the sort of, ever-changing air quality recommendations and regulations as well. There are sort of if you can also start to think about how to incorporate this into your clinical risk assessment. And this is a paper by Michael Hadley, where they sort of institute a very sort of a brief survey about their potential risk from household air pollution as well as outdoor air pollution. There are ways, you can sort of put in their, home zip code or where they're from to try to identify how much exposure they potentially had. And this is just kind of a mock-up, but kind of this is what we imagine will be, you have this ASCVD calculator that eventually sort of includes your average PM2.5 exposure into the calculation. But I think we're not quite there, and that still has to do with sort of, having a better monitoring, having a better estimate of your individual, PM2.5 exposure levels as well. And so, we're cardiologists. We like randomized clinical trials, but unfortunately, we don't quite have that for targeted intervention in air quality reduction, air quality improvement. And so there are some studies looking at this face mask, and this is done in China. This is an open randomized crossover trial that they looked at. It's basically just some markers of sort of symptom, blood pressure, heart rate variability, ST depression after 24-hour sort of experiment with mask. It's not quite really the standard that we kind of expect to use for any type of implementing a intervention. And then air purifier, there was a study published in JACC where they looked at 35 healthy college students randomized to true or sham purifiers, and they looked at biomarkers and lung function, blood pressure. And they found the inflammatory markers decreased and blood pressure improved following these interventions. But we still need more data to, I think, try to sort of institute a evidence-based approach for intervention. There are several ongoing trials of portable air filtration, and these are all kind of funded by NIH trials, R01 trials. This one is called Puri HF trial. It's actually being done in India with the NIH money, and this is looking at effectiveness of indoor air purifier, heart failure functional capacity, 6-minute walk test among patients with HFrEF. And then Aspire trial, this is done in the kind of Ohio region, looking at simple face mask as well as in-home air purifier system, looking at the cardiometabolic outcomes. Another trial is done around Detroit, and this is determining if long-term air filtration unit leads to cardiometabolic outcomes or improvement of that. There's a study in New York by Jonathan Newman as well, looking at PACs, portable air filtration units, looking at blood pressure measurements as well. So there are, I think it's being done. There are better studies coming forward trying to look at these targeted intervention, which are limited. I think the options are limited. We have face mask, we have air filtration unit, but I think it's still a good next step to try to figure that out. We have a few minutes. So I'm just going to talk briefly about wildfire and vaping, but this is actually kind of personal to us too. Wildfire, I think this is back in 2020 September. I think Palo Alto was like this as well. New York last year had sort of a massive wildfire plume as well, and this was sort of in 2023, 2020. These are the 4 worst wildfire smoke days in recent U.S. history. The levels of the region where the wildfire can go up to PM2.5 level above 400, 500. But with that, basically the population average in the US goes up to about 20 to 30 range when you have these type of events, which is much higher than our average of 9 generally in the US. And the composition of the wildfire smoke, it contains a lot of the things that we saw in this air pollution, but carbon dioxide, monoxide, particulate matter, hydrocarbons. The actual composition can sort of differ depending on the smoke, I guess the fuel type, the temperature of the fire, wind conditions, but it really contains sort of similar to the air pollution and cigarette smoke. And when you sort of look at, there's really no long-term data, I guess, to look at wildfire at this point, but just on the short-term data, even in California, the wildfire episodes were associated with increased cardiovascular events and cerebrovascular events, ER visits. And then I think what's concerning is that there's, up to 2050, the estimate is that there's going to be increased wildfire potential, looking at some of these index like the drought index. And it's the Amazon, this Rockies, Sierra Nevada, they're all sort of regions where the drought is going to just increase. And there's going to be sort of estimated 2 more months of these type of high fire risk timing at the time. And then this is vaping. This is at a vaping convention in Maryland. And you can imagine what the PM 2.5 level is in this room, but it's in the thousands. And these are the levels here. But what's concerning is that this vaping and e-cig market is really rapidly growing in the US, and really among the youth, this is a big problem as well. And you can see that any tobacco product use in high school is at 25–30%. And now this dotted line here is the e-cigarettes, and it's really rapidly increasing and taking sort of the bulk of that tobacco use. And this also introduces kids to sort of a gateway to actual tobacco use as well. And if you look at the breakdown products of e-cig, they're very similar. When you look at they have particulate matters. They also have these carbonyls and formaldehyde, acrolein, volatile organic compounds, metals. And there's been studies looking at the effect of e-cig on cardiovascular disease, but I think suffice to say that it increases your blood pressure, increases inflammatory markers, cell adhesion biomarkers, reduces your vascular, causes vascular dysfunction or endothelial dysfunction. And there's been a circulation scientific statement talking about the potential mechanism, how that works. I guess our lab, my lab here is looking at this impact as well. And we basically expose mice to e-cig and vaping. This is This is basically a Joule device connected to a mice chamber. And then we perform what's called the single cell sequencing to try to look at what that does to each individual cell type. And we found that it can cause this sort of proteotoxic stress and protein folding issues in these muscle cells. And we've validated that in vitro models as well. So we're trying to look at how e-cig causes increased proteotoxicity as well as atherosclerosis and what sort of that pathway might be. So just to summarize that part 2, I think reduction in PM 2.5 can improve public health through reduced risk of cardiovascular disease. I think recognizing the significant environmental inequity and the vulnerable population is important for us as clinicians. Intervention to reduce exposure should be approached with both patient-centric and more of a societal government view. And physician and patient education regarding harm of air pollution is important. And incorporating the PM 2.5 exposures as a modifying risk factor, I think we should all sort of keep that in mind. I think there's the problem with the intervention itself can be a bit difficult, but I think when you identify a high-risk patient with high exposure, I think you just do a better job at your usual primary prevention with your statins and blood pressure control, all that, and recognize what the preventive measures to reduce exposures are. And I think just recognizing that wildfire and vaping are a significant source of particle pollution exposure as well. So with that, I just want to thank everyone, and thanks for coming. Okay.